down and kind of forward. And what you can have your patient do is that you're just going to have them swallow a couple times. And you're feeling for that hyoid bone to lift up and then come back down, okay? So just really appreciating the edges of the hyoid bone and not adding too much pressure of where it's at. But as they swallow, you'll definitely feel it where they'll lift up and then come back down into your fingertips as it relaxes, okay? Next is the sternocleidomastoid. Just finding, really just seeing, you can really see the attachments to the clavicle. And so if I put them into a little bit of a stretch, I definitely get probably some sort of striations, but you're looking
what beautiful sternocleidomastoid Wyatt has.
So again, going from the mastoid process, coming down, you can see it almost where it almost fans out on the clavicle. And then, again, appreciating the head and actually see it coming down towards the
You can see the two heads really clearly on Wyatt, the clavicular and the manubrial.
Yeah. So again, just appreciating kind of where that's at, how it attaches to different sections of it. And
you know what I like most about Wyatt is his sternocleidomastoids.
Yeah, very, very attractive. Sternocleidomastoid. And then next, the scalene muscles. Again, with these, it's just more displacement, but what we're trying to get to eventually is to where the first rib is at. So again, we can kind of put them on stretch just with a simple side nod, and going around where the sternocleidomastoid is at, you can appreciate where the scalenes are at. And again, a little bit of side nod, you're going to feel that tension in there. So to push, or to get through the scalenes, I'm going to relax them by going into a side nod towards me. And then I'm going to add pressure, kind of almost kind of down and just back towards the spine. And what I'm feeling for is the first rib. So if we use our skeleton friend, you can see where the first rib is at here. So again, you're just pushing down and kind of back towards, and it's just going to be a flat surface. It's just going to feel hard, like nothing really gives. You can also go from through the trap. Again, kind of hard to get through, but again, we can put it on slack by just doing a slight side nod, and I'm going to push down into the middle portion of the upper trap. Okay, and again, this happens a lot. I think I tell this story every year, but you'll have some clinicians out there that will be just getting on this trigger point until it cannot relax anymore, and they're saying, why do they keep on having this knot? Or a patient will come in and say, why do I have this knot that's always just right here? Well, it's not a knot, it's a bone. And so, you know, if you spend too much time rubbing in that area, it's not going to feel that good. So it's good to know the anatomy and where it's at, so you know that, you know, in order to tell people, hey, you know, what you're feeling is not, it might be tender in that area, but that hardness, that kind of firmness that you feel is probably more so after you get through the muscle, the first rib. And so just knowing with where that at. I had a lady, it was a while ago, she was born without a first rib, and it was just one side versus the other, and she had just a lot of different neck issues. But it was really interesting to push down and not feel anything when you're so used to feeling a first rib whenever you palpate in an area. But let's.
Were her scalings just attached to the second rib? Just all of them?
Say what? Sorry.
Were her scalings attached to the second rib, just all of them? Or did she have issues with like the scaling development if she didn't have her first rib?
Yeah, I honestly, I don't know how it develops or whatnot. They move to a different attachment or they just never grow in, but she just was never born with one. So I forget what the condition name is. Dr. Hackney, you might know. It was a long time ago, but it was really interesting. Anyways, they also will remove the first rib for TOS issues, so they'll completely extract them for some cases for a very extreme TOS. So, you know, it's just good to know where it's at in space, so you're just not rubbing on a bone trying to get a muscle to relax when it's not a muscle. Okay?
So,
yeah, go ahead.
oh, what is TLS?
Oh, thoracic outlet syndrome. Sorry.
So, but actually, so like, since there are some muscles that are attached to the first rib, so if they
To start off, I have the deep neck flexors, and the first muscle in that group of three is the longus capitis, and its origin is on the anterior tubercle of the transverse process of C3 to C6, and the attachment is the inferior surface of the basilar part of the occipital bone. So, it's right up in here. And the innervation is the ventral rami. The next muscle is the longus colli. The origin is the vertical portion of C5 through T3 vertebrae. The inferior oblique portion is the T1 through T3, and the superior oblique is the anterior tubercle of the transverse process of C3 to C5. And since it's got three parts, it looks like this skeleton. And that innervation is the ventral rami as well. And the last one is the rectus capitis, which is a smaller muscle. It's the lateral mass of the atlas for the origin, and the attachment is the base of the occipital bone in front of the foramen magnum, and the innervation is ventral rami. So it's right up here, and it runs horizontally. And then to test these, you would have the patient lay on their back, and you would have them, you'd have them put their hands like this on the table, and then go into cervical flexion, and then you would just tell them when, be good, and that's a test for that one. And the next muscle group that I have is the anterior lateral neck flexor, which is just the sternocleidomastoid. The sternal head is the anterior surface of the manubrium, and the clavicular head is the upper and medial 1/3 of the clavicle, and it attaches on the lateral surface of the mastoid process in the lateral half of the nuchal line of the occipital bone. So that goes right like this. Good. And then that the innervation is the spinal accessory nerve. And to test that one, you would have them do the same position right here, and then have them come up and look to the left. And then you would put your hand on like the temporal space and say, resist me, good. And then for the other side, you can come up and twist the head, and then you would say, resist me, good.
Include sort of a chin tuck, so bringing the chin toward the Adam's apple. If you go forward like this, if you imagine like lying on your back and going forward like this, then you're actually lengthening the deep neck flexors. You get a lot of sternocleidomastoid actually either way, but this allows you to shorten the deep neck flexors rather than lengthen the deep neck flexors while you're testing. That was a really good job.
Hello, everyone. My name is Chris Slutchower. I'm your classmate today, and I have 5 muscles that I'm going to teach you. So, first I'm going to introduce the posterior lateral neck extensors, and then I'm going to get into the upper trap and the levator scapula. Okay, so first we have the splenius capitis, which is innervated by the posterior rami, the middle cervical nerve, and its actions are to bilaterally extend the head unilaterally and laterally bends and rotates to the same side. Next we have the splenius cervicis, which is innervated by the posterior rami also, and lower cervical nerves, and its action is to bilaterally extend the head unilaterally and laterally bends and rotates the head to the same side. Last of the posterior neck extensors is the semispinalis, and its innervation is the posterior rami as well, and its action is to extend and laterally rotate the head, or contralaterally rotate the head. And then I'm going to introduce the other 2 muscles. So we have the levator scapula, which its innervation is the dorsal scapular nerve, and it elevates the scapula. And then we have the upper trap. So the upper trap innervation is the motor accessory nerve, and its action is to elevate the scapula, or the top portion is to elevate the scapula, middle is to retract the scapula, the lower portion is to depress the scapula. So our attachment points, you can see our friend Freddie.
That's very good.
Looks good. Okay, for the splenius capitis, the origin is the nuchal ligament, and the spinous process of C7 to T4, and it goes to the mastoid process and superior nuchal line. So it's kind of like this. Almost. And then for the splenius cervicis, it's the spinous process of T3 to T6, and its attachment is transverse process of C1 to C3. So it's about right, kind of like this. And then we have our semispinalis, which is the transverse process of C4 to T10, and its attachment is spinous process of C2 to C6. So it's about kind of like that. And then the other two muscles, we have the transverse process of C1 through C4. This is for the levator scap and the medial border of the scapula. So C1 through C4, about right here. Transverse process. And then we have the upper trap, which is the spinous process of C7 to T12, and superior nuchal line and occipital bone. And then its attachment is the clavicle acromion and spinous scap. So upper one is about right here. Can't really do that one. But. All right. So first, for the posterior lateral neck extensors, I'm going to have Amanda lay down here, and she's going to lay supine. Or prone, I should say. My bad.
Wrong word came out. It happens to me all the time, unfortunately.
And then I'm going to have her turn her head to the side here. You guys will see.
Pretty good.
Okay. And then I'm going to press down just like this, and she's going to resist me. Good. And then for the levator scap, and for the levator scap, I'm going to have her sit back up. I'm going to have her put her hand across her head, and I'm going to have her stretch herself, and then I'm just going to apply just a little bit of pressure along with that. And then for the last one, which is the upper trapezius, I'm going to have a similar motion. She's going to be to the side, and she's going to be pulling, and I'm just going to apply a little bit of pressure along with that. And that is my presentation.
Guys, that was really, really good. I want to show you a couple of additional manual stretches for those muscles, because as you guys have probably experienced, because you spend so much time doing this, right? So exactly, so first of all, you're probably on a laptop or using a keyboard, and the keyboard is too low, so you have to go like this in order to get your fingers to it. And then the the keyboard's too high, so you have to go like this. And then the screen is too low, so you got to go like this. And so those muscles get really tight and painful. So Amanda, would you be my stretch model, or does somebody else want to be the stretch model? You want to be the stretch model? Okay, good. All right, lie supine, please. So you can have your head here. All right. Actually, that's not bad. All right, so actually, if you take your jacket off, please. Yeah. T-shirt will be okay, though. Okay, very good. So first of all, as I think that Chris pointed out, the upper trapezius, so far as the motion of the head, is a contralateral rotator. So to stretch it, you go ipsilateral. So to stretch the upper trapezius, and actually scoot toward me a little bit. Boy, you got such long hair. Okay, so it would probably be helpful to use your, is that showing up pretty well? Yeah, good. Use your stomach or your hip, and then pressure down on the spine of the scapula, laterally flex away, flex, and then it's laterally rotate. Like that. So try this one out too. And I'm going to get you just a little bit higher for the next technique. And for levator scalp, and this is a really common problem for a lot of people who work on a keyboard. The grip is kind of similar, but for the head, but then you put your thenar eminence, really, or your hyperthenar eminence, the heel of your hand, on the on the supermedial corner of the scapula, and then stretch again with flexion and contralateral side flexion, but then also contralateral rotation. So try these guys out as well when you're working on these, okay? All right.
Very last ones before we're all done. Well, I don't know if I have to introduce myself, but my name is Susanna Konchak, and we're going to do the sternocleidomastoid, everybody's favorite muscle. I don't know if you can see. Yeah, that's okay. So the origin of this is the mastoid process of the temporal bone, and it inserts, there's two heads. There's the manubrium, or the sternal head, which attaches to the manubrium right there. Whoop. And then there is the clavicular head, which attaches to the medial third of the clavicle, which is going to be right here. Yeah, it's pretty decent. And the innervation of this is the spinal accessory nerve 11, which is actually both for these and the scalenes. And it does lateral flexion and rotation of the neck when acting unilaterally, and extension of the neck at that atlanto-occipital joint when acting bilaterally. So because I didn't know what that meant, it does this like this little tiny motion. But what I'm going to have my patient do is I would have her look up. Can you see? Yes, I'll have her look up. And just, yeah, so I'll have her look up and put her chin to the ceiling. And then I might give a little bit of a stretch. In fact, I'd probably go over here. Stabilize this shoulder. Hair out of the way. Stabilize the shoulder and have her sit up nice and straight and tall. Excellent. And then give that bit of a stretch. And then same to the other side. I wouldn't do it too much or too long because I did it yesterday and I hurt my neck. So don't do that.
Oh no.
I know. I was kind of scared because I did it and it some popped and I was like, oh, let's not. So then the other one, which are going to be the scalings. Take this guy back. So then there's three scalings. There's the anterior, which goes from the anterior tubercle of the transverse process of C3 through C6. I'm going to give it my best, right there, to, there's a couple of those, and then it goes to the first rib, here. Then we've got the, insertion is at the inner border of the first rib, and then the middle scalings goes from the posterior tubercle of the transverse process of C3 to C6, so posterior, the transverse process. And then that's going to go to also the first rib. And then we've got the last one, which is the posterior scalings, which goes the posterior tubercle of the transverse process of C5 through C7, so a little bit lower. And it goes and inserts to the second rib, which also helps with inspiration, so that's fun. They're all innervated by, well, the anterior ones are innervated by C5 through C6. Anterior rami, the intermediate ones are going to be innervated by C3 through C8. Anterior rami and the posterior are going to be innervated by C6 through C8 anterior rami. And the action is elevation of the first rib, so that's going to be for the anterior and middle, and then elevation for the second rib for the posterior. And then they also do ipsilateral lateral flexion of the neck. So what I would have the patient do, it was a fun stretch I saw someone do for all of them. I would have the patient raise their head, sit up nice and tall, raise their head, and then I would have them look to one side, and then as they keep stretching to the right side, so if you were going to put the head over to that side. I'm so sorry. Okay, I would have them bring their head This way? Yes, that's right. And then what I would have them do is slowly keep looking down, and that's going to stretch all of them. So this is right now stretching the posterior scalenes, doing this way is stretching the middle, and doing this way is stretching the anterior scalenes. And do it on the other side.
But who has heard of torticollis? Show of hands if you have. All right. Now, torticollis is usually, babies are born with it a lot of times, and it gets worse as they mature. But it's a congenital muscle tightness. And what's really interesting, I think, and what will really help you think about some of the directions of these rather long cervical muscles is to go through it with your fingers. Now, for most people, including me, you get the longest reach between your bird finger here and your thumb. So if we're interested in thinking about what maximally, everybody do this with me. So take your hand like this, maybe put your thumb on the spine of the scapula, even the acromion if you'll reach, and then the tip of your bird finger on the occiput, the nuchal line actually, where the upper trapezius attaches, and to maximally lengthen it, you can feel how you have the flexion, side flexion, and then ipsilateral rotation. If you go into contralateral rotation, it shortens it a little bit because it brings your fingers closer together, right? The Sternocleidomastoid is also an interesting one too. So do the same thing. Everybody do this with me, okay? Again, bird finger up on the mastoid process where it attaches cranially, and then down toward the sternal-manubrial joint where it attaches more caudally. And then to maximally shorten it, you side flex ipsilaterally, contralaterally and flex, and then contralaterally rotate to maximally lengthen it, go in the opposite direction, right? So some extension, contralateral rotation, and ipsilateral side flexion. So if you're not sure about what maximally lengthens or shortens these muscles, just test it out with your fingers. It's a really nifty way to experience it, okay? All right, so
nail these down to know where you're at in space. You'll get into even more specifics about finding each individual level of the spine to do a certain medium muscle test or something like that. You'll get into that later. So we're just going to hit kind of the highlights of C1 and 2, and then trying to differentiate between C6, 7, and T1 since they're all kind of close together. Okay. So first off, we'll just start with the back of the skull. The occipital protuberance is important just so we know we're not trying to kind of differentiate between when we start feeling the spinous processes versus feeling the back of the skull. I usually start with a finger and just come down until I feel kind of the first bump, and then it will immediately drop off into this space where you just don't really feel a whole lot. So what's the main ligament back here that's preventing me from feeling a whole lot in this position? Nuchal ligament, yeah. And so then we'll also find the nuchal line, so occipital protuberance. As it comes around, it's just going to be a small ridge. It's nothing too prominent, okay, but we know that we have a lot of muscles that attach to that small rib, okay, so just appreciating where that's at in space. So again, the nuchal ligament, so to make it a little bit more tight, to really emphasize it, I can bring it down into flexion, and you can really feel that in that space where the ligament tightens up, and then as I bring him kind of into extension, just a little bit of a nod, you can definitely feel where it lessens up quite a bit, okay? So a little bit straighter there. Forget all y'all students, so posture is definitely something you all need to work on.
bless their hearts.
Bless your hearts, yeah. Bless you. So the first spinous process that I'm going to feel for, is it going to be C1 or C2? 2. Hey, did you guys already go through this, I'm guessing?
Yeah, we did.
So smart. So C2, because C1 doesn't necessarily have one, right? But we can feel the transverse processes of C1, and they are right beside the mastoid process. So I'm going to come behind the ear. I can feel for the mastoid process, and then in between that and really the TMJ region, we can have a finger in there, and that is C1. So it's really important to recognize just how high it is, kind of where it's at in space, because you probably wouldn't, honestly think about where it's at until you appreciate where the two spinous processes are at. So we can also do, just to emphasize a little bit more, and do just like kind of side nodding. I don't know if you guys have worked on C1 movements yet, but how could I emphasize it? If I was testing his right side, would I side bend him towards me or away from me? There's about a 50-50 shot there.
Towards.
Well, what are you trying to look at, Dr. Adler?
To
emphasize it under your hand?
Yeah, underneath my hand.
Towards.
What do you mean?
Towards.
I still think
You guys should look that up. It's like a 50-50 shot.
Towards. It's towards.
It is towards. Yeah. If you want to feel it just a little bit more, you can. And then coming back to the occipital protuberance, I'm coming down in a neutral spine position. I'm going to add just a little bit of pressure until I reach my first spinous process, which is right about here. So about the hairline for a lot of people, a little bit above, but that is going to be my C2. So right there. And then as you're coming down, you can really try to attempt to count each one. So it's going to be kind of a hill and then a valley, hill and then a valley as you come all the way down to C6, 7, and T1. A lot of times C7 is going to be the most prominent, but it's not that way all the time. So a lot of times what I'll do is come down to what I feel like is the most prominent. So he has kind of two right here that I feel like are the most prominent. So I'm going to put 2 fingers on each one, and then I'm going to slowly start, just relax, slowly start bringing them into extension. And so what I'm feeling for is for whatever one moves first, okay? And so whatever one moves first is the level above, so it might be C6, C7, okay? So if I'm still not unsure, then I'm going to bring my ring finger, my middle finger, and then my index finger on what I think is the next one, and then I can do it. Okay, so his head starts moving a little bit sooner here on this vertebrae on my finger, so I would assume that this is C6. And then if I keep on going to extension, the middle finger starts to move a little bit more, so I would assume that's C7 instead of T1. T1 doesn't have much movement with neck extension. And to make sure I can keep it here, I'm going to place a hand on the sternum. I'm actually going to push back into towards the spine. And what I can feel is that T1 pushes into my index finger. So you'll feel the ribs are actually pushing the spinous process back into kind of push into your finger. If you want to feel it just a little bit more, you can. And then coming back to the occipital protuberance, I'm coming down in a neutral spine position. I'm going to add just a little bit of pressure until I reach my first spinous process, which is right about here. So about the hairline for a lot of people, a little bit above, but that is going to be my C2. So right there. And then as you're coming down, you can really try to attempt to count each one. So it's going to be kind of a hill and then a valley, hill and then a valley as you come all the way down to C6, 7, and T1. A lot of times C7 is going to be the most prominent, but it's not that way all the time. So a lot of times what I'll do is come down to what I feel like is the most prominent. So he has kind of 2 right here that I feel like are the most prominent. So I'm going to put 2 fingers on each one, and then I'm going to slowly start, just relax, slowly start bringing them into extension. And so what I'm feeling for is for whatever one moves first, okay? And so whatever one moves first is the level above, so it might be C6, C7, okay? So if I'm still not unsure, then I'm going to bring my ring finger, my middle finger, and then my index finger on what I think is the next one, and then I can do it. Okay, so his head starts moving a little bit sooner here on this vertebrae on my finger, so I would assume that this is C6. And then if I keep on going to do extension, the middle finger starts to move a little bit more, so I would assume that's C7 instead of T1. T1 doesn't have much movement with neck extension. And to make sure I can keep it here, I'm going to place a hand on the sternum. I'm actually going to push back into towards the spine. And what I can feel is that T1 pushes into my index finger. So you'll feel the ribs are actually pushing the spinous process back into